All right. Hey, everybody, welcome back to the Medical Biochemical Genetics Clinical Course Seminar Series. We're happy this week to have Dr. Sean McCandless from University of Colorado to talk about amino acid disorders. It's the second part of that lecture. He'll be talking about PKU and tyrosinemia and classic homocystinuria. So we'll look forward to that. Just some housekeeping reminders. You're going to have the code pop up in the chat if you want to get CME credit. The code changes every week. So the code for this week will pop up and you can enter it into the phone number that's given, text it, or go to the Children's Continuing Education website for Children's Colorado and enter it there for CME credit. The lecture is being recorded as always. It's going to be archived hopefully this afternoon. I'm traveling, but I'm hoping that Dr. Barshop will be able to upload it within a few hours after the talk. And last week, and actually a little bit the week before, we had issues with folks unmuting or not muting themselves when they got on. I've adjusted the settings, so everybody should be muted as they get on. If I'll be patrolling again, but hopefully we won't have the same interruptions that we had last week. It's very distracting. Please save your questions for the end. I think that probably works the best for the flow of the discussion and the lecture. And there should be time at the end to ask Dr. McCandless anything that's on your mind. Fellows, you're especially encouraged to ask questions. I'm gonna give it over to you, Sean, and you can start and share your screen.
Thank you very much. Looks like you should now be able to see my screen, and thanks for the opportunity. I'll say again that I can already see that there's people on this call who, there's actually one or two people that have been doing this longer than I have, just a couple, but there's quite a few people who know more about these topics than I do. So I'm counting on you guys to jump in if I get something that's not quite right, or to add your insights later when we get to the questions. Just to point out, many of these slides are adapted from the one of the NAMA talks, and I'm realizing that I didn't do a good job of setting up my screen, so I'm looking away from the camera when I'm looking at the screen. So I apologize for that. Hopefully you guys are looking at the slides and not at me anyways. So the topic for today, as we said, is amino acids and amino acidopathies, and specifically PKU, tyrosinemias, and homocystinuria. Some of the slides are from NAMA, and for those of you who are old enough, an old Monty Python reference. So I wanted to start a little bit by just reminding you about the structure of amino acids and a little bit about amino acid metabolism. There's amino acids are carboxylic acids with an amino group here, so that's what makes it an amino acid. And then there's a variety of side chains attached to this alpha carbon. And so the carboxyl group, the amine group, and then the side chain. And the side chains can have a variety of organic structures, and that determines the class of the amino acid. So there's carboxyl groups, there's groups that have an extra amine group on them, there's hydroxylated compounds, there's the imidazole, which is one compound, the guanidinium compounds like arginine, and then the thiols that are sulfur-containing amino acids. So a wide variety of side chains, and each of those side chains, in the process of oxidizing amino acids, each of those side chains has to be metabolized in some way, and there's a variety of mechanisms through which that happens. When you think about the protein content of the diet, you eat protein, your body breaks it down to the amino acid constituents. Those amino acids are then used for a variety of purposes. The biggest function of the amino acids in your body is to make new protein. And the source of amino acids is both dietary and from endogenous breakdown of proteins in the body. But amino acids are also used for the formation of a variety of other compounds, neurotransmitters, hormones, and amino acids, particularly the carbon backbone of the amino acids, can be used for energy metabolism. And we'll talk about that more in a minute. When you think about protein metabolism in the standard 70 kilogram adult that we all met briefly in medical school and then have never seen again. The 70 kilo person is made up of about 11 kilos of protein. And of course, 60% of that 70 kilo person is water. And then the remainder are, the remainder of the compounds are fats and a small amount of carbohydrate in the body, and then and trace minerals, with calcium being an important one. Not that that matters. The proteins in your body undergo constant proteolysis, and there's about 300 grams per day in an average adult that are being broken down. And you have an equal amount of protein synthesis each day. So that should be in balance, 300 grams in, 300 grams out. And the amount of free amino acids that are coming into the body each day the need for free amino acids are based on the irreversible degradation or the oxidation of the amino acids, either that are from the diet or from this proteolysis of the proteins in the body. So the 70 grams per day roughly is what you need to replace from the diet each day. And then there is some de novo synthesis of the non-essential amino acids. There's some loss of amino acids to specific functions, including, as we said, creation of neurotransmitters, but that's a very tiny fraction of the free amino acid pool. The bulk of the free amino acids coming in are either used for protein synthesis or are degraded through oxidation. And remember that the only way your body has to store protein or to store amino acids is in the form of proteins. There's no other way to store amino acids. And amino acids are, amino acid concentrations are not the drivers of protein synthesis. So if you take if you're a weightlifter and you gulp down tons of amino acid solution before you go lift weight, that will not drive you to make more protein. And so you would get much more benefit by going and lifting weights and then adding extra protein supplement through the next 24 hours as your body, through various signaling pathways, is driving the synthesis of new proteins in response to your exercise. You want to make sure you have amino acids available. But if you take a large amount of free amino acids or a large amount of protein at any one time, basically what you do is you flood the liver with amino acids, and the concentration when the concentration in the liver is high, you will then just oxidize the excess. You see that too, even in dietary formulas that contain free amino acids. The oxidation rate of those free amino acids is higher, about 40% higher than the baseline oxidation rate for intact protein, just because you're getting higher concentrations in the liver in a short period of time in the absorptive phase of that meal. This is basically showing all the different ways that your body makes energy. And I want to focus on the right side and just to say things that we've already talked about, that you have amino acids that are coming from protein or coming from the diet. Those amino acids can be used to make new protein, or they can be broken down. And you heard last week about the first step in that is the deamination or transamination step. That removes the amino group, and that goes through the urea cycle in the hepatocytes, particularly the periportal hepatocytes, to make urea. What's left after you remove that amino group is an organic acid, and that organic acid can be metabolized in several ways. The backbone can be used to make pyruvate. The backbone can be used to make propionic acid or propionate. That feeds into the TCA cycle, the Krebs cycle, or the pyruvate can feed into the Krebs cycle. And eventually what you get is complete oxidation via the Krebs cycle with the production of ATP from the use of energy. So that's sort of the 10,000-foot view of that. I'm not going to go into too much detail. Everybody on this call will recognize the Krebs cycle here. You recognize that there's various entry points to the Krebs cycle through oxaloacetate, through alpha-ketoglutarate, through succinate. You'll remember, and various amino acids enter the Krebs cycle through at different points. So the ketogenic amino acids, which are phenylalanine, tyrosine, leucine, lysine, tryptophan, eventually get made into ketone bodies, acetoacetyl-CoA, circulate through the body, or are that acetoacetyl-CoA can be further broken down to acetyl-CoA, which typically is going to go through the Krebs cycle for energy production, or do any of the other things that acetyl-CoA does. If you have an excess of acetyl-CoA, you'll make fat from it. So a variety of pathways. Other carbon backbones of amino acids that you can see listed here will make pyruvate and enter the Krebs cycle through that mechanism, through pyruvate, and either through the carboxylation, which can be then used to make glucose, or can go through the Krebs cycle, or basically the oxidation of pyruvate through pyruvate dehydrogenase to make acetyl-CoA that then goes into the Krebs cycle. A few a few of them amino acid backbones get made into glutamate, while amino acids get made into glutamate, and then glutamate gets transaminated to make alpha-ketoglutarate, and that's another entry point to Krebs cycle. The propiogenic amino acids, isoleucine, methionine, valine, and threonine, get made into propionic acid and via then methylmalonic acid made into succinic and succinyl-CoA and enter that way. And then a couple of the amino acids can also be broken down through different pathways to fumarate and enter the Krebs cycle in that pathway. So a variety of different ways to oxidize amino acids using a variety of different pathways. Just to think a little bit about the amino acid content of muscle, 30 grams of muscle contains about 6.25 grams of protein, and that 6.25 grams of protein is about 1 gram of nitrogen, just to kind of give a sense of the proportions. And if you think about the content of amino acids in various proteins, that is determined entirely by the DNA sequence of the gene that codes for that protein. And so there's nothing about, there's nothing about the diet, the amino acid makeup of the diet that determines the amino acid makeup of the protein in your body. That's entirely determined by your genes, by your DNA. And in muscle, which is the primary storage place for proteins in your body. So if your body is needing to for some reason, because of starvation, is requiring protein for energy, or is requiring protein because of amino acid deficiencies, and you need additional amino acids for protein synthesis to occur, you primarily break down muscle first. And muscle is not made up of 5% of each of the 20 amino acids in equal proportion. The 20 amino acids that go into human proteins are distributed differently. So methionine makes up about 2% of the amino acid load of muscle. Leucine, far and away the highest, 8.5%. This is why catabolism is so bad for people with MSUD, because catabolism, where you're breaking down muscle, you're disproportionately releasing leucine. And then some of the other ones are kind of where you would expect them to be with the 5%. Amino acids can be synthesized. The non-essential amino acids can be synthesized, and that's the definition of it. An essential amino acid, by definition, is one that cannot be synthesized by humans. It has to come from exogenous sources, food. Non-essential amino acids can be, and of course, you all know that there are amino acids like arginine that, as long as you have a functional urea cycle, it's a non-essential amino acid because you can synthesize arginine. But if you have a defect in that pathway, arginine now becomes an essential amino acid. So there are some amino acids that are variable and can become essential amino acids under certain metabolic circumstances. Amino acids can be classified as essential and non-essential, and I've listed them here that you can refer to later if you need to. Sorry, I thought I had another listing that showed the propiogenic and the gluconeo or the ketogenic, and there's different ways that people break down amino acids. We already showed the side chain breakdown and classification. Just to talk a little bit more, I already mentioned this before, but the content, and again, you can go back to this as a resource after the talk to kind of tuck these numbers away and think through the calculations. But again, the muscle is about 20% protein. The nitrogen protein of content of nitrogen protein content is 16%. So if you think about it, 30 grams, the way it works out is 30 grams of muscle, 6.2 grams of protein, 1 gram of nitrogen. As you're thinking about sort of the results of catabolism, or if you're thinking about how dietary protein is broken down, that 30 grams of protein or 6 grams of protein is going to be about 1 gram of nitrogen. We already talked about both of these things. So when you think about PKU as sort of the classic example of an amino acidopathy, you can see that in a typical individual who has all of their metabolic pathways working normally, you break down about 100 grams of muscle a day. That releases about 20 grams of protein that then produce about 20 grams of amino acid, or a little bit less than that, and about 3 grams of nitrogen. Leucine, isoleucine, and other things are broken down. The amino acids are broken down to go through the Krebs cycle to make CO2 and water. Nitrogen goes through the urea cycle. In PKU, unfortunately, you can't further metabolize phenylalanine, so it has nowhere to go. So it just accumulates. That's really kind of obvious. There's nothing special about that. You all knew that. There is a very clear relationship between weight or body size and urinary nitrogen excretion in the form of urea that is shown here. And basically, you can see that it's a very linear relationship to body surface area. And as most of you know, that in a smaller body below about 20 kilograms, there's a pretty direct relationship between body surface area and weight. So that's why when you think about drug dosing, all of the most drugs will say up to 20 kilos, you can use milligrams per kilo. After 20 kilos, they often recommend using body surface area for dosing. And that's because beyond 20 or 25 kilos, the slope of the body surface area relationship to drug metabolism gets further and further away from the per kilo dosing. And so the bigger you are, the less useful per kilo dosing is. But you can see that this nitrogen excretion is very, very linear relationship with body surface area. And that's in a variety of different states: sepsis, elective surgery, and many other states. This is a very old study from the 1980s. Just a couple of more final thoughts about protein intake. Food is a source of exogenous protein. Digestion creates free amino acids and di and tripeptides typically. Those di and tripeptides, and even there are a small amount of slightly larger peptides that can be absorbed from the gut. And that's why nursing mothers sometimes will be able to pass on allergens through their breast milk, because not every protein that they ingest is completely degraded to free amino acids prior to entering the breast milk. Just a little aside, there are both essential and non-essential amino acids. This exogenous intake is what makes up for the 70 or 80 grams of protein that we oxidize each day. You all know that defective intake or inefficient or inadequate intake of protein can lead to 2 different deficiency states: kwashiorkor, which is a protein-only deficiency, and marasmus, which is a generalized calorie and protein deficiency. And we we should be thinking about kwashiorkor on a regular basis because we actually occasionally induce that in some of our patients with our diets, but also by just the fact that many of our patients are protein averse over many years and just don't take what they need to take in terms of protein. So even though we're prescribing the appropriate amount of protein to keep them healthy, they may not be taking what we think they are, and they may develop kwashiorkor with all the complications of that, edema, skin rashes, GI symptoms, and eventually more serious problems. So now I'll get into the disorders that we're going to talk about today, the amino acidopathies. The majority of these can be identified and are identified by newborn screening, but not all of them. And in fact, we'll talk about homocysteine toward the end of the talk, which is inadequately identified by newborn screening for reasons that we'll talk about now and again on the 19th of August when we talk about newborn screening. Phenylalanine, as you know, is an essential amino acid. It's required for the synthesis of proteins. It is a precursor to tyrosine. So if you have PKU, tyrosine is no longer a non-essential amino acid. It's now an essential amino acid. And the only source of tyrosine that you have is your dietary intake of tyrosine. Catecholamines, including dopamine, are formed from tyrosine, serotonin, and melanin. Serotonin is not made from tyrosine, it's made from tryptophan, but there is a relationship to phenylalanine that you'll see in a minute. The hyperphenylalanemias are the various abnormalities that are, this is one way of classifying defects in phenylalanine metabolism, and these are pretty widely considered classifications. There's what we call classic PKU, classic phenylketonuria, and that's a case where the untreated PKU is above this arbitrary number of around 1,200 micromoles per liter. And I will encourage each of you to get in the habit of using the international units, micromoles per liter, as opposed to the old-fashioned American approach of using milligrams per deciliter. All of you know that the conversion factor is roughly 60. It's actually 59.7 or something like that. Micromoles per liter equals 1 milligram per deciliter of phenylalanine. But it's really good to get in the habit of using these numbers so that when we speak with anyone anywhere in the world, we're on the same page. So untreated classic PKU is an untreated plasma Phe concentration of greater than 1,200 micromolar. Mild PKU is when in the untreated state, typically above 600 but below 1,200, and that's a relatively rare condition. And then what people often refer to as hyper-Phe or hyperphenylalanemia is when the untreated phenylalanine is less than 600. 600 is kind of the magic number because there have been some studies that suggest that individuals with mild hyper-Phe who don't routinely go above 600 don't appear to develop the neurologic abnormalities that occur in people that have higher concentrations of blood phenylalanine. I think we have to be really careful about that, and I think that that's reflected in it's reflected in a variety of data that have that been published in the past 15 years or so, but it's also reflected in the expert guidelines for the management of phenylketonuria, where the goal is to keep the blood Phe below 360 micromolar, as opposed to below 600 micromolar. But we do still tend to use 600 as at the point at which we would intervene with dietary intervention. We would put somebody on a protein restricted diet if they get above 600. As you're all aware, people with PKU, people with hyper-Phe, during periods of catabolism, acute intermittent or intercurrent viral illnesses, will have higher phenylalanine measurements. And I kind of like to, for my hyper-Phe patients, I like to measure I tend to measure their Phes when they're well, but I do like to measure their Phes from time to time when they are sick, just to make sure that they're not intermittently going higher than I think they are, because I don't know what the long-term consequences of that are, and I may be a little bit more likely to start therapy if they're going over 600 during illness. The other thing that I don't think I talk about here is that we don't often give a lot of thought to when we test when we test amino acids, when we test plasma amino acids. But all of us have seen plasma amino acid reports where you have a variety of amino acids that are elevated. You particularly see it in kids on elemental formulas. And that's when the amino acids are collected within 2 or 3 hours of a feeding, particularly with an elemental formula, but it can be even just a protein feed. You see it in the NICU all the time with newborn screening, and that's led to several publications that have recommended that newborn screens in babies in the NICU on TPN, you should stop TPN for a few hours before you draw the newborn screen to avoid that situation. What is clear is that measuring amino acids in the postprandial state can give you artificial elevations. Most of the time when we're measuring amino acids in the clinic, we're doing it because we want to make sure that we are not over-restricting proteins. Therefore, it's really important that we don't measure a postprandial sample, because you could be fooled into thinking that your person has adequate protein intake by having normal amino acid concentrations when they're postprandial, when the reality is if you did that in a fasting state or a preprandial state, you're more likely to see any deficiencies of amino acids that would be reflective of an over restriction of protein. So as metabolic specialists, we have to be really intentional about when we measure the amino acids to make sure that we're getting information that we want, that we're actually measuring what we think we're measuring. Now, does it matter whether it's preprandial or fasting first thing in the morning? I don't know. I haven't seen data to support that. So I tend to do either. I tend to like to be at least 4 hours after a meal in older people and 2 to 3 hours after a meal in infants when I test the amino acids. Now, you all know that the primary defect in PKU, phenylketonuria, is a deficiency of the phenylalanine hydroxylase enzyme. You see a nice pretty picture of it here. Phenylalanine hydroxylase is a homotetramer. 4 copies of the PAH gene come together to form the active site. And as you can imagine, a homotetramer can have a variety of conformations, some of which are more active than others. We'll talk about that more in a few minutes. There is a required cofactor for phenylalanine hydroxylase to be active, and that is tetrahydrobiopterin. Tetrahydrobiopterin has a synthesis defect, a synthesis pathway in the body so that you make biopterin. And any defect in that pathway of synthesizing biopterin or in the pathway of reactivating biopterin after it has been hydrolyzed will also cause a deficiency of tetrahydrobiopterin. Tetrahydrobiopterin deficiency causes deficiency of phenylalanine hydroxylase activity. It also causes a deficiency of 2 other enzymes that use tetrahydrobiopterin as a cofactor, tyrosine hydroxylase, which is required for dopamine synthesis, and tryptophan hydroxylase, which is required for serotonin synthesis. And that, as you all know, is the reason that people with these defects in biopterin synthesis pathways they are much more challenging to treat and manage in terms of neurodevelopment, because even when you treat the PKU effectively, you don't necessarily replace the dopamine and serotonin in the CNS. And so developmental abnormalities are common in those kids unless you're very careful about treatment. And even then, with adequate treatment, with replacement of biopterin, you can still see neurodevelopmental abnormalities in those individuals. Just talk a little bit about that protein the homotetramer that we talked about before. It is a dimer of dimers. So you first form a dimer of 2 molecules, and then those 2 molecules interact to form this active site here in the middle. There is allosteric changes that lead to different folding states for the homotetramer. And it's interesting to note that biopterin has been shown to stabilize the tetramer, but biopterin alone stabilizes it in the lower activity allosteric form, and that so that PAH activity is higher when the phenylalanine concentration is higher, because that's what triggers the conformational change that really activates PAH. And that makes perfect sense, because you don't want PAH to be overactive when you don't need to oxidize phenylalanine. When you're trying to maintain phenylalanine for protein synthesis, you don't want a high rate of oxidation. So it makes perfect evolutionary sense that this allosteric activation by phenylalanine would occur. As you all know, PKU is due to the autosomal recessive dysfunction in phenylalanine hydroxylase, and has an incidence of about 1 in 16,000 in the live births in the US, with some various ethnic disparities. Some groups have higher rates than others. I think that's everything I wanted to mention there. Just to go back, I think this is the, I believe this is the tetrahydrobiopterin binding. Other causes of hyperphagia we talked a little bit about. There's rare variants. These explain about 1% of the severe hyperphagia cases of PKU. So they're rare. They're all individually rare. As a group, they're rare, but they certainly are important, and they're critically important to rule out. If you have a patient with PKU, you need to rule out these 1% of rare causes, because they will not be adequately treated and their neurologic development will not be optimized if you don't recognize that they need more than just treatment of phenylalanine. GTP cyclohydrolase, dihydropteridine reductase, one of the more commons, the 6-pyruvyl tetrahydrobiopterin synthase, all of those require treatment with tetrahydrobiopterin. They usually require additional supplementation with DOPA for dopamine, and they require dietary treatment to maintain or some other form of treatment to maintain the phenylalanine in the normal range. And then the pterin alpha carbanolamine dehydratase is generally mild, and those kids are often diagnosed if you have access to measuring urinary biopterins, because they excrete this abnormal 7-biopterin. And then there is another recently described protein, DNA JC12, that's a molecular chaperone for the hydroxylases. And so it causes similar to the biopterin synthesis defect, causes defects in both PAH, tyrosine hydroxylase, and tryptophan hydroxylase. So also harder to treat and may require supplementation with DOPA in addition to managing the hyperphenylalaninemia. So there are a variety of ways of getting to the diagnosis. Typically these days, far and away the simplest approach is to do sequencing. To do a panel of these genes is the best, in my opinion. You could just sequence PAH, and if you find 2 clearly pathological mutations that are in trans, that's probably adequate diagnosis. In the past, more commonly in Europe, but in some clinics here in the US, we would not start dietary treatment immediately in the newborn period, but would give kids a couple of doses of tetrahydrobiopterin or sapropterin and look for a response with a reduction in the phenylalanine of 30% or greater over the first 24 hours of therapy, which would be a very strong indicator of a biopterin synthesis defect. It's important to remember that if you do that, if you give a dose of sapropterin in the newborn period, you see that reduction. That documents that this is a defect in biopterin synthesis and changes your treatment plan. But if you don't see a response, what that does not tell you is whether your patient has a biopterin responsive form of hyperphagia. We'll talk about that more in a few minutes. But if you really want it later, as the kid gets older, then if you've done a challenge in the newborn period for 24 hours before starting diet, and you go ahead and need to start diet, then what we typically recommend is then at a later age, if the mutations are ones that suggest that they might be biopterin responsive, or in more specifically sapropterin responsive, then we suggest that you do a 30-day clinical trial with sapropterin, looking for that 30% reduction in baseline Phe. And you do that while they're on diet. So if they're running Phes of 450, you're looking for a 30% reduction in that when you put them on sapropterin. And that can take longer for reasons that aren't entirely clear to me, other than it's likely due to a chaperone effect of the sapropterin on the both the individual proteins and on the homotetramers. And so it may take time for that responsiveness to become apparent. Untreated PKU, probably many of you are familiar with this disorder, but untreated PKU is a really terrible disease. There's still patients around that were untreated. Many of them are getting older. Many of them are institutionalized at this point. But very rarely you will see a person with unexplained intellectual disability who, for whatever reason, was missed by newborn screening. So there are still cases of untreated PKU around. Development is normal in quotation marks, typically for 6 to 9 months, and then slowing of development, slowing of head growth. And then by the time the kids are a year to 15 months old, they're very clearly developmentally delayed. They are lightly pigmented for their family because they don't make melanin properly. They may have this musty odor that's similar to mouse urine. Just reminds me of Doug Kerr trying to collect mouse urine in his garage because he loved to make fellows and residents smell all the different metabolic disorders. And many of them will have seizures. They have severe intellectual disability and very severe behavior problems. The behavior is often very difficult to control. And many of these individuals in the past have ended up in institutions just because of the behavior problems in addition to the intellectual disability. And they may actually develop white matter hyperintensities on MRI. So a missed case could look like a leukodystrophy initially when you see the kids, and that's been sometimes referred to as pseudoleukodystrophy. So the pathophysiology of hyperphenylalaninemia, I think, is not completely understood. But I'll tell you what I think our current understanding is. First off, it's related to elevated total body phenylalanine, and particularly to excessive phenylalanine in the brain. There appears to be reduced transport of large neutral amino acids into the brain. That the LAT1 transporter transports phenylalanine, tyrosine, and tryptophan into the brain. And when you have an excess of phenylalanine in the blood, there's a competitive disadvantage to tyrosine and tryptophan to get into the central nervous system via that LAT1 active transport system. And so you have measurably reduced concentrations of tyrosine and tryptophan in the brain. There's also evidence that excess phenylalanine in the CNS inhibits the tyrosine hydroxylase and the tryptophan hydroxylase enzymes. And so you get reduced synthesis of key neurotransmitters, especially during development. And that's really important, not so much for kids with PKU, who probably in the fetal life, if their mother's doesn't have PKU, during fetal development, the child will have normal phenylalanine concentrations, the fetus will, but after birth, this becomes a problem. But this is likely the mechanism for the defect that we see in maternal PKU, where you have inhibition of synthesis of neurotransmitters in the developing brain due to the high phenylalanine exposure from untreated maternal PKU. There is no known direct pathologic effect of phenylalanine on the liver. So you don't get liver disease from phenylalanine. So now I'm going to shift gears and start talking about treatment of PKU. Treatment is, the goals of treatment are normal development, normal growth, normal social interactions, normal micronutrient concentrations, and normal bone calcium. And the targets that we typically use, as I said before, are plasma phenylalanine of 120 to 360 micromoles per liter, and plasma tyrosine in the normal range. I should also add that with some of the newer treatments, you can actually become phenylalanine deficient. We do try to avoid phenylalanine deficiency and tyrosine deficiency in the treatment. The mainstay of therapy for PKU remains dietary phenylalanine reduction and restriction, and that's usually requires reduction in or restriction of intact protein. There is also the ability to use, people have suggested that you might have a competitive, if part of the problem is the transport with the neutral amino acid large neutral amino acid transporter, that if you give supplements of the other large neutral amino acids, that might compete. We'll talk about that more in a minute. Chaperone therapy has been shown to be effective in some cases. And then the newest treatment is the enzyme substitution therapy. There are experimental therapies that are currently being tested, including gut biome, manipulation of the gut biome to limit absorption of phenylalanine, or to destroy or to oxidize phenylalanine in the gut before it can be absorbed. And there are also gene correction or gene replacement strategies that are being considered and tested. And so it seems likely to me that that will eventually be where we end up, but that remains to be seen. Diet therapy, as I said, remains the mainstay. We restrict dietary intact protein and ensure that we're giving an adequate amount of phenylalanine in the diet to replace the need for replacing phenylalanine that for whatever reason. And that in most people with classic PKU turns out to be 250 to 350 milligrams per day. Remember that a gram of dietary protein is about 50 milligrams of phenylalanine. So even for an adult who can their tolerance in classical PKU is 350 milligrams of phenylalanine per day, that's 7 grams of protein. That's less than a tenth of what we think is the typical protein need for an adult. So the ability to take intact protein in classic PKU is incredibly low. And that's why this diet is so challenging. And it's why we need better therapies. That said, breastfeeding is often manageable, especially in the first 3 to 6 months of life, where there's very rapid growth and the protein needs are higher, phenylalanine needs are higher. You can get away with giving more phenylalanine in a breastfeeding baby. And so breastfeeding is often manageable in the newborn period. And I think that we owe it to our families to try to find a strategy for breastfeeding. We'll talk more about that in a minute. And then if you're only given 10% of the protein needs as intact protein, you have to replace that with medical foods. And remember that there are a variety of options for that. You give the non-offending amino acids. Glycomacropeptides, which are produced from casein, have been shown to be naturally low in phenylalanine, and there are a variety of quite palatable foods now being produced from these glycomacropeptides. You also need to make sure that you're getting vitamins and minerals that are necessary, because we're limiting dairy in the diet, and we're limiting protein in the diet that may bring along other micronutrients. And the other thing to remember is that your need for amino acids is kind of constant through the day. That's not exactly the same at every point in the day, but it's not, you can't give all the protein in one fell swoop during the day and then have 22 hours where you don't have any amino acids available. That will not work. You have to distribute the protein through the day. And then I think most importantly is that in the past, there was a suggestion that once brain development was complete, back in the day, 4 to 6 years of age, maybe 10, you could stop diet and people would be okay. We now know that that is not true. People with well-treated PKU who go off diet have very significant neurocognitive effects from that. There's one study that shows that a person with controlled PKU who goes off diet and their blood phenylalanine concentration goes up, you can measure a 15-point loss in IQ related to that that increase in phenylalanine, and that is reversible at least after a short period of time. So just being acutely hyperphenylalanemic reduces your IQ. What you hear from patients is they'll describe, my thinking is cloudy, I have trouble I can't do math, can't do the crossword puzzle, can't make sense of newspaper articles, can't balance my checkbook. So diet for life, you need treatment for your entire life for PKU. Strategies for breastfeeding, very quickly. Some people will try alternating between one breast milk feeding and one bottle feeding with a medical formula. Other people will take a fixed amount of breast milk as the source of the intact protein and use that. Breast milk tends to be pretty reliable and it works pretty well, but because we don't really have a way to measure the protein content of the breast milk you're using, you have to sometimes manipulate that based on growth and based on plasma amino acids. And then other people have done with every feeding, you give the prescribed amount of metabolic formula, and then you let the baby go on the breast. And I would just say, if you're going to do that, if you're going to try that approach, it's maybe best to have the baby only nurse on one breast at each feeding where you're doing that, so that they can get through the front milk and then get to the fat-rich, protein-lower hind milk from that one breast, rather than just taking the water and protein-rich front milk from both breasts. I'm not going to go through the list, but these are sort of the phenylalanine tolerance and tyrosine needs and protein needs based on different ages. And you can see that sort of 4 years to adult, most kids are most people are between 200 and 1100 milligrams per day of tolerance. They need lots more tyrosine. And because you're using elemental amino acids there, which are oxidized more rapidly than the amino acids coming from intact protein, because you're getting higher concentrations of free amino acids in the liver, you need more protein. And so the metabolic experts typically recommend aiming for 20 to 40% above the daily recommended intake of total protein. And remember, most of that's probably going to be coming from medical foods. Monitoring, we want to make sure that we're providing adequate calories, providing adequate protein, vitamins, and minerals in our prescription. But our prescription is not always what our patients are doing. And so we also need to monitor biomarkers of appropriate diet. And those are, most importantly, diet growth and development, and blood phenylalanine and tyrosine. We monitor other parameters. I think it goes without saying, but I'm going to say it anyways. Collaboration with a knowledgeable dietitian in inborn errors of metabolism and PKU is absolutely critical to the management of these patients. Those people on this call who are metabolic experts will tell you that the dietitians manage the PKU patients, not the docs. We're just there to make sure we're there as backup. But the dietitians really are the ones who manage this, or at least that's the way it used to be. Now that there's more medical treatments, we have a bigger role. How frequently do you need to measure phenylalanine and tyrosine? Nobody knows. There are very clear recommendations that are based on sort of the opinions of experts, as best I can tell. What makes sense, though, is when you're growing rapidly, when things are changing rapidly, when your diet's changing rapidly, your need for protein is changing rapidly, you should be testing more frequently. So at the time of diagnosis, most people test either daily or every other day. And typically when a new baby is diagnosed, you'll put them on an entirely phenylalanine-free formula for a few days. The phenylalanine concentrations typically go down by about 50% every 48 hours. So if a kid comes in at 1500, you put them on phenylalanine-free formula, they are likely to be around 700 in 2 days. So you can often get away with waiting a day for checking that next phenylalanine. But it's important to remember that it really depends on where they are in a growth spurt. It also depends on how much catch-up they have. So if they've been, for some reason, well nourished prior to that, they may actually be already growing rapidly at that point and they may use phenylalanine faster. So you don't want it. What you don't want to do ideally is overshoot. Although anybody who's done this before will tell you that most of us have overshot quite often. It's not atypical for us to sort of get the second or third phenylalanine measurement and it's 35 or 20, and kids tolerate that just fine. But you have to be checking frequently to make sure that you're optimizing the diet. And then you keep checking frequently until you've figured out how much phenylalanine that baby needs per kilo. And then you can start to back off. And so a lot of times by the time the kids are 6 weeks old, 2 months old, we may have backed off to check in just once a week. And you can use dried blood spot phenylalanines. You can use plasma phenylalanine. I prefer plasma because there tends to be more variation in the dried blood spot phenylalanine. And if you do comparison between plasma and dried blood spots, you'll see a lot of variation. And it's weird because sometimes the dried blood spots will be higher, sometimes they'll be lower. And the thing to remember about dried blood spots is that you're not measuring plasma phenylalanine, you're measuring whole blood phenylalanine and tyrosine. And so there's other factors that go into it. The hematocrit matters. There's lots of other factors that matter for dried blood spots. The reality, though, is that dried blood spots, if that's what you're using, that can be a very effective tool to use. And if that's what works for your families, you shouldn't, I think, hesitate. You shouldn't hesitate to use it. After the first year of life, most people test either twice a month or monthly. If child's poorly controlled, or if they have a prolonged illness or a chronic illness or some dietary abnormality, you may need to check more frequently. And do be aware that phenylalanines will get quite high during intercurrent illness. In addition to checking Phe and tyrosine, it's important to also from time to time monitor other nutritional factors. Growth you should be measuring, you should be carefully monitoring. And we tend to measure plasma amino acids fairly frequently to make sure that we're not over restricting, that the other essential amino acids are all adequate and that tyrosine is adequate. You can measure transthyretin as another measurement of adequacy of protein intake. The micronutrients, particularly vitamin D, are very important to monitor. Some people monitor ferritin and iron. And you'll see if you go to gene reviews or go to the guidelines that there's a long list of other things that people have suggested it might be worth testing from time to time. Usually those other things you monitor twice in the first couple of years and then once a year after that. I didn't mention it here, but I do think I tend to try to get neuropsych testing on my patients with PKU before they start elementary school, and then again sometime later in their educational career, and not wait for them to have problems in school before we do the testing. Not everybody does that though. So I want to talk a little bit about the other therapies besides dietary therapy. The first is the large neutral amino acids. And again, the goals of therapy is to increase the plasma tyrosine and to reduce the CNS phenylalanine concentrations. And so the way large neutral amino acids work is they're just a medical food that is highly concentrated in tyrosine, tryptophan, and a couple of other large neutral amino acids or larger amino acids. They become part of your medical food prescription. And the beauty of them is that they work by competing with phenylalanine absorption, both from the gut and crossing the blood-brain barrier. And so you don't have to have any PAH enzyme for them to work. That said, it's still not clear how effective they are. The data on efficacy are very mixed. Early studies suggested that you could get reduced plasma phenylalanine concentration and reduced CNS phenylalanine concentrations. Later data suggests that may not be the case. You definitely get an improvement in plasma tyrosine because there's a ton of tyrosine there. There's also some suggestion that you get improved CNS tyrosine, but also there have been a couple of more recent papers that suggest that even if you don't get changes in plasma concentrations, you may see a more favorable pattern of CNS large neutral amino acids that is reflected in improvements in neuropsychological measurements. I've not had very many patients that we were able to use these and make them work. But some people do, and it's something to keep in your back pocket if you have a patient that you're just not getting very effective dietary therapy and you feel like you have to try something else. Again, just to remind you, the large, that LAT1 is the neutral amino acid transporter. This is the blood side, transports into the brain endothelial cell and then out into the CSF on the other side of the brain endothelial blood-brain barrier. And you can see that the CAT1Y plus is the lysine, arginine, ornithine transporter that we think about if we're, trying to treat pyruvate, or not pyruvate, but pyridoxine-dependent epilepsy or glutaric aciduria. And then again, the idea of the large neutral amino acids is that you're, and this is what's not clear is whether this is really a significant part of the pathophysiology of PKU or not. But the idea is that if you've got an excess of phenylalanine, then phenylalanine is out competing tyrosine and tryptophan for the transport into the CNS. So you end up with excess phenylalanine in the CNS and a reduction of other large neutral amino acids in the CNS, and that then interferes with CNS protein synthesis, interferes with neurotransmitter synthesis. But we also, as we said, phenylalanine appears to damage myelin, appears to inhibit tyrosine and tryptophan hydroxylase, and causes a lot of other problems. So likely phenylalanine itself has some toxicity in the CNS. The deficiency of tryptophan and tyrosine has some toxicity in the CNS, and altogether you get the neurocognitive defects of PKU. And that you get the neurocognitive defects that can become permanent if you go through critical periods of brain development, but they can also be temporary when you don't have well-controlled phenylalanine. And now, every one of you has seen a classic PKU patient who goes off diet as an adult and functions really well. I suspect if we did really, really careful neuropsych testing, many of those patients would actually have clear markers of improvement when their phenylalanine concentration is controlled. But I don't think that study has been done. And some of those adults don't feel much different. Some do, some don't. Other therapies, sapropterin. Again, the goal here is to enhance phenylalanine tolerance, but it's also to normalize diet, or to maybe not completely normalize, but to improve the tolerance for intact protein and intact phenylalanine. Sapropterin, as you know, is a biopterin analog, binds very strongly to PAH, also binds to tyrosine and tryptophan hydroxylase. The typical, it's given orally, it's a once a day dosing, about 20 milligrams per kilo per day is a typical dose. Does not require titration of the dose. You can start there. Some people will use higher doses if you're not getting an effect with the lower dose. And it's not clear to me that that works, but some people have done that. There's a couple of variants that may give you a little bit more chaperone effect if you have higher concentrations. We already talked about trying a 24-hour trial in infants if you want to. I think most people don't. In the US, most people do. In Europe, beyond in older kids, you want to treat for a longer period of time before you determine if they are before you say that they're not responsive, because there does appear to be some gradual onset in some patients with some mutations. And remember, it does take, you have to have some PAH protein for sapropterin to work. This is a partial list of mutations that have been shown to be effective, where sapropterin appears to be responsive or not responsive. And you can see here that some of them sort of, very few people with these variants are going to be responsive. These variants tend to be very responsive, these point mutations. There's a splicing variant that there's mixed data for. So I think if you have evidence of a missense variant, you're likely to have some protein. It's not wrong. It would be a good idea to try sapropterin. where most, I think in many clinics where sapropterin is most helpful is in the kids with hyper-Phe or mild PKU tend to be the most responsive to sapropterin. And many of those kids can really have a great improvement in their dietary treatment and get much better control with sapropterin. So it's worth trying. In those patients in whom sapropterin doesn't get you where you need to be, we now have access to pegvaliase, which is the plant enzyme phenylalanine ammonia lyase, which is not a human enzyme, which causes a problem because of foreign protein, which are given to people, and so you can have immune response to that. You can also it's called pegvaliase because the enzyme is pegylated, meaning that it's coated with polyethylene glycol, and there's some evidence that polyethylene glycol can cause hypersensitivity reactions as well. A couple of things to know about this. It is an enzyme replacement therapy. It is a plant enzyme, so you get a lot of immunologic response to that. It does not replace tyrosine because phenylalanine ammonia lyase does not make tyrosine like phenylalanine hydroxylase does. So you still have to supplement tyrosine in people that are on this, but sometimes their dietary tyrosine may be adequate. Immunologic reactions are the norm and must be managed. It is not approved for use in pregnancy and not recommended for use in pregnancy. That said, if you are on it and stable and pregnant, most people recommend staying on it. And I'm not aware to date of any reports of adverse pregnancy outcomes from the moms who have remained on pegvaliase. But there are people on this call who may be more knowledgeable about that than I am. So during the questions, if I didn't get that right, please pipe in. And the drug is approved for use in adults. So it's not available for use in younger children yet. It's a subcutaneous injection. Typically, it's dosed daily, and the typical dose is about 20 milligrams per day because it's only used in adults. There's not a per kilo dose. There are titration instructions in the package insert that I'll show you in a minute. The response is defined by at least a 20% reduction in baseline plasma phenylalanine. And I think it's important to measure that a few times on a stable diet before you start the treatment so that you've got kind of a really solid baseline on diet. And you don't stop diet, you keep them on diet when you start pegvaliase. And then you, as their blood Phes get lower and lower, then you start to manipulate the diet. The other thing is that because the immunologic response is different and there can be neutralizing antibodies, every person responds differently, and it can take over a year for people to show the response. And some people actually need a higher dose. So some people end up on 40 milligrams per day, and that's 40 milligrams, not 40 milligrams per kilo. But you have to stay on a long time before you can say that somebody fails. And again, the titration plan, you start with 2.5 milligrams once a week for 4 weeks, and then you very gradually increase. You treat the symptoms, the joint swelling and joint aches that people get, the acute the acute reactions as people get at the site. Very rarely people will get full-blown anaphylaxis. That thankfully is rare, but it's very, very important that you have patients be observed when they're dosing and that they have access to epinephrine injections when you're starting them on pegvaliase. And then the recommendation is that if they don't respond at 20 milligrams, that you do go after 24 weeks, you do go up to 40 milligrams daily and give them 16 weeks on that. So it does take over a year to say that somebody is definitely a non-responder. And there's no particular reason for someone to be a non-responder because you don't need phenylalanine hydroxylase protein. So it's really about the breakdown of it's about the breakdown of the drug by the immune system. And I see that there's some discussion going on in the chat that I'm not able to really pay attention to, but there are some comments from others who are knowledgeable about this in the chat. Maternal PKU, Neil Kirkman back in the 60s said, if we start treating PKU, we're going to end up with a problem of mothers who go off diet and have babies that are damaged by phenylalanine. That was true. And it's very clear that phenylalanine is a teratogen for the reasons we described earlier. A baby born to a mother with untreated PKU or even inadequately treated PKU will have microcephaly. Cardiac lesions are common. Intellectual disability is common. Microcephaly is the most common, though. I have yet to see a baby born to a mom who was not well controlled during pregnancy that didn't have microcephaly. And it's really shame. It's really a shame, but it's also, there's a hard disease to treat. And you can't judge a young woman for relaxing her diet. And unfortunately, many pregnancies, it's in my experience, somewhat unusual for a woman to come to clinic before she plans a pregnancy to get her diet well controlled. We do see it from time to time, usually in patients that have been very compulsive and that we see in clinic regularly anyways. And those are great cases to work with. More often, mom comes in at 18 to 20 weeks of pregnancy with a fee of $1,500 or $2,000, and you've already lost the battle for the heart defects because embryogenesis is complete at that point. If they're going to get a heart defect, they've already got it. Intellectual disability is an issue, learning disabilities and microcephaly in those kids frequently, even with adequate treatment. So ideal treatment, aggressive therapy before pregnancy. I can't emphasize that enough. You should be talking about this with your PKU, your girls with PKU. You should be talking about this during childhood, during adolescence, and every visit when they're an adult. And you need to ask them if they're sexually active. You need to ask them if they're using birth control. You need to ask them if they're pregnant. The fee should be in the target range, 120 to 360 micromolar, as early as possible for unplanned pregnancies. And some people will even put a person in the hospital for a couple of days so you can check the fee daily, get that down very quickly. You have to give tyrosine supplements, especially in the third trimester. These babies are sucking up phenylalanine. And so you need to be monitoring phenylalanine and tyrosine very frequently, often weekly or even twice a week during the third trimester, because the baby is then sucking up phenylalanine, sucking up tyrosine, and moms who are well controlled will get low in both of those things. And you often can't get enough tyrosine in the diet that you have to give supplemental tyrosine to these moms during in the third trimester. Sapropterin seems to be safe, and if you're well controlled on sapropterin, you should continue using it. And as I said before, we don't have good data yet, but as somebody mentioned in the chat, I believe that the company that makes pegvaliase is really monitoring cases of pregnancy carefully. In my opinion, and I think most experts' opinion, is that we know that uncontrolled PKU is very, very bad for a pregnancy. And we know that somebody who's been stable on pegvaliase and eating a normal diet is going to have a hard time with dietary control for 9 months. So it seems like the risks of staying on pegvaliase probably are outweighed by the benefits at this time, but we don't know that. And it has to be a decision that your patient makes with you after careful consideration. And then if you do decide to continue, we would ask that you communicate with the manufacturer and make sure that those data are collected for outcomes. So some universal lessons about PKU now before we move on. The first is that screening and treatment for these disorders can be effective. Newborn screening, when you start doing it, you uncover milder forms for which the need to treat may not be obvious. And this is true of just about every condition we've added to newborn screening. There may be unanticipated future consequences when you begin treating an inborn error of metabolism, as we see with maternal PKU. Treatment and intervention creates a new natural history. So even if you think you understand the natural history of the disease, once you start treating it, Pompe is a great example of this. You're going to see things you didn't know you were going to see once you have a group of treated patients. And that can change then the treatment. And the pathogenesis is almost definitely more complicated than you think. And alternative therapies are going to be developed over time. And we need to keep thinking about, there's not a single genetic disorder or metabolic disease that we have the final solution for. So we need to keep working on better treatments and better solutions for these people. So now I want to shift gears a little bit and talk about tyrosine. And we'll go through this a lot more quickly, just because the conditions are more rare. Much of the basis is the same for treatment, understanding the treatment. The tyrosine catabolic pathway you've all seen starts with the synthesis of tyrosine from phenylalanine via phenylalanine hydroxylase. You've got tyrosine aminotransferase that converts tyrosine to 4-hydroxyphenylpyruvate, and that deficiency of that enzyme is very rare, but we do see it. That's type 2 tyrosinemia. Conversion of 4-hydroxyphenylpyruvate to homogentisic acid is from this 4-hydroxyphenylpyruvate dioxygenase disease gene, and that is the cause of tyrosinemia type 3, which is even more rare. And just to point out, this is the mechanism of action of nitisinone, the drug that we use to treat type 1 tyrosinemia, is by we give this drug that blocks this enzyme activity at this HPD level, and you then block the formation of the substrate that is the cause of the problem in tyrosinemia type 1, but you convert tyrosinemia type 1 to tyrosinemia type 3. So you still have to treat the tyrosinemia, but that's dietary treatment, whereas the treatment for tyrosinemia type 1 does not respond to just dietary tyrosine restriction. You then homogentisic undergoes conversion to malonyl acetoacetate, which is made into fumarate acetoacetate, and fumarate acetoacetate is broken down by fumarate acetoacetate hydrolase, or fumarate acetoacetyl hydrolase to make fumarate and acetoacetate. And you may remember seeing phenylalanine going into the Krebs cycle through two different directions. That's why you make fumarate and you make acetoacetate. So two different entry points to the Krebs cycle for the carbon backbone of phenylalanine. Fumarate acetoacetate, if you are missing fumarate acetoacetate hydrolase, if you have a block, autosomal recessive block in that, you have tyrosinemia type 1. You accumulate an abnormal metabolite called succinyl acetoacetate, which makes succinyl acetone, which is the marker that we use. Fumarate acetoacetate, allylyl acetoacetate, and succinyl acetoacetate all appear to be toxic, particularly to liver and proximal tubule kidney cells. Succinyl acetone also interferes with porphobilinogen synthase, which is responsible for converting aminolevulinic acid to porphobilinogen. Now, you all know that that enzyme is a deficiency of that enzyme is a form of porphyria. So you get, in people with type 1 tyrosinemia, you can get porphyric crises, abdominal pain, neurologic crises, psychological neuropsych changes as a result of the inhibition of this enzyme. You also get the renal Fanconi syndrome because of damage to the proximal tubule cells from succinyl acetone and possibly fumarate acetoacetate as well. And then it's thought that this is the compound that causes the liver injury. Regardless, as a result, you get lots of different types of damage from type 1 tyrosinemia. So it's a really, really bad disease. We already mentioned most of this stuff. There is a founder effect. So my friend David Rosenblatt, who I saw on this call, has probably seen a lot more than any of the rest of us, because there's a group of Quebecois folks that have a founder effect. There's a founder effect in northern Finland, as there is for just about every genetic disease. And then there are really three ways that this condition presents. Type 1 tyrosinemia presents in early infancy with liver disease, one of the more common forms. And those kids will go on to develop liver synthetic defects and complete liver failure and require a transplant early in infancy if they're not treated. In late infancy, if the liver survives without liver failure, you may see rickets due to the Fanconi syndrome, the renal Fanconi syndrome, and the tubulopathy that you get from that. And then occasionally you'll see somebody who doesn't present until later who comes up with porphyria-like attacks, neuropsych abnormalities, episodes of abdominal pain. And so you have to keep that in the back of your mind because these kids can escape detection and present later in life. We already talked about this. The important thing to remember, if this is not an intoxication disorder, so you don't get acute metabolic, you don't get an acute intoxication symptom or syndrome with these disorders. So it's not like MSUD, where when your leucine gets very high, you all of a sudden look drunk, or when your ammonia goes up, you look drunk. These cause chronic damage from the toxicity. The damage is hepatocellular, leading to cirrhosis, leading to hepatocellular carcinoma, and that is often indicated by. And you can also get benign tumors that later then become malignant tumors. Alpha-fetoprotein can be high. Alpha-fetoprotein can be high with or without a tumor. You get renal tubular damage. Even if you replace the liver, you can still get renal tubular damage because that's thought to be a local effect of in the proximal tubules. So even if you transplant the liver, you probably need to keep a little bit of drug on board. We already talked a little bit about the porphyria-like abdominal crises and peripheral neuropathy that are due to the delta aminolevulinic acid or porphobilinogen synthase defect. And then of course, succinylacetone also goes back up and inhibits that hydroxyphenylpyruvic dioxygenase, so that you're converting basically that's what causes the high tyrosine. The important take-home message there is that tyrosine 1 rarely presents with massively elevated tyrosine. So if a baby comes in with a tyrosine of 1200, that's probably not tyrosinemia type 1. And in fact, when people looked at tyrosinemia or tyrosine as a marker for newborn screening, what we found is that it's unusual for a baby in the newborn period to have a tyrosine that is above the range, above the 95th percentile of what you see in normal children. So tyrosine is not a marker, a newborn screening marker for tyrosinemia. And if you're in a state, I don't think there's any states left that were doing this, but many states for many years were screening for tyrosine and said, we're screening for tyrosine type 1. That has been proven to not work. You have to measure succinylacetone in the dried blood spot if you're going to screen for tyrosinemia type 1. Or in Quebec, they actually do DNA screening because they have a founder mutation. But dried blood spot screening for succinylacetone is a highly effective way of newborn screening. And you need to make sure your state or your country, wherever you are, that that's what they're doing. Treatment. We already talked about NTBC, nitisinone, that's 2-nitro-4-trifluoromethylbenzoyl 1,3-cyclohexane-dione. Part of your oral quiz at the end of this will be to say that 3 times fast. It inhibits the 4-hydroxyphenylpyruvic dioxygenase, so it creates tyrosinemia type 3. And you get a much bigger increase in tyrosine, which you then have to treat with dietary tyrosine reduction. But it reduces the production of fumarole acetoacetate and succinylacetone, and reduces the kidney and eliminates the kidney and liver damage. What it doesn't do is it doesn't completely eliminate the hepatocellular carcinoma risk, so you still have to monitor for that. You then have to restrict phenylalanine and tyrosine to treat the tyrosinemia, because if you don't, you'll get symptoms from that we'll talk about in a minute. And then if you do get carcinoma, people recommend a liver transplant. The earlier you start treatment, the better. Children that start treatment in the first few months of life have an extremely low risk of hepatocellular carcinoma. Kids who present at 2 years of age and get started on treatment have a fairly significant later incidence or prevalence of tumor. So earlier treatment is better and needed. So the response is basically with a drug concentration of greater than 35 micromolar of the drug, you inhibit 99.9% of the enzyme. And so it has been suggested by many authors that you can just use your drug concentration as the treatment goal. If you're above 35 micromolar for your drug, you're adequately treating the condition. Some of us don't trust that and also like to monitor the plasma succinylacetone to see complete suppression. And what I found when you do that is that not everybody requires a blood concentration that high to keep their succinylacetone completely normal. And what I think many of us have found is that the higher the dose of nitisinone, the more difficult it is to control the tyrosine. And so some of us like to play around, and maybe we're playing with fire, but we try to play around with the dosing to kind of optimize the minimal, to optimize the dietary treatment while still keeping the succinylacetone fully suppressed. And so like I will sometimes let people grow into their dose, and then when the succinylacetone, when I start to see a little bump in the succinylacetone, that's when I increase the dose. I don't know if that's a good idea or not. So, you know, I think you have to use your own judgment about that. But your goal should be complete suppression of succinylacetone. It's easy enough to do. If you are using the drug concentration, you can be fairly confident at above 35 micromolar that you're achieving that. There is dry blood spot testing available. My experience has been that the number one, the concentration of the drug is different in the dry blood spot than it is in plasma. And so I don't think it's as reliable to use the drug concentration as your marker. I've also seen quite a lot of variability in the tyrosine between plasma measurements, and I've seen a lot of variability in the succinylacetone between plasma measurements. So I think it can't, like for PKU monitoring, it can be useful, but just be aware that it may have more variability than what you will see in plasma measurements. And I'll leave it at that. I'm not going to talk about that. There are, you know, we talked about the other defects. If you have a baby that comes in with tyrosinemia on newborn screening with very high tyrosine, you know, then you're always stuck with, is this liver disease? Is this, you know, is this transient tyrosinemia of the newborn? There's other ways that you can identify that. These metabolites that I've listed here, the 4-hydroxy, the 4-hydroxyphenyl, remember that's the R group on the tyrosine, and the side chain on the tyrosine. And you get all kinds of crazy organic acids when you see those things. And so you'll see those in your organic acids measurements in kids that have liver disease or have these conditions. Type 2 tyrosinemia is the tyrosine transaminase. Very, very rare, thought to be around 1 in a million, also referred to as Rickner-Hanhart. Those kids often develop corneal crystals in the first year of life, and those are extremely painful. They come in with red eyes, photophobia, tearing. They eventually will get corneal clouding if untreated, and it can often be mistaken before blood testing was easy to do. Can be mistaken for other kinds of problems, viral infections or herpes. They also get plantar palmar hyperkeratosis. About 80% of people who develop this can appear at any time in the lifetime of these kids. They can have, they can be pitting. So that I don't know if you can appreciate, but there's some little pits in these thickened plaques on this kid's feet. They're often painful. This histology is non-specific, so a dermatologist will biopsy this and won't be able to tell you that it's tyrosinemia type 2, but most dermatologists will take a look at this and say, gosh, that seems like tyrosinemia type 2, and they'll send the test, or they'll call you and ask you to test. Up to 60% of kids with untreated type 2 will have intellectual disability. So it is important to treat, but typically this becomes apparent later in life, and that's good for us because you don't have to treat a high tyrosine in the first month of life. You can give it time and see if it's transient hypertyrosinemia of the newborn, which most often it is. It will get better on its own. So a high tyrosine, you see a baby with a very high tyrosine on newborn screening, repeat succinylacetone to make sure it's not tyrosinemia type 1, because you don't want to miss that. Once you know it's not tyrosinemia type 1, people recommend waiting 4 to 6 weeks and repeating the tyrosine. If it's type 2, it will still be very, very high. If it's transient, it will be normal, or it will be approaching normal. So if you wait 6 weeks, the tyrosine has come from 900 to 210. It's almost certainly not tyrosinemia type 2. You probably don't need to repeat it a third time in a month to show that it's completely normal, but many people do, just because we always like to have normal values in the chart. But that the key is high tyrosine on a newborn screen. Make sure it's not tyrosinemia type 1. Then just put your hands in your pockets, walk around the block, and wait 4 to 6 weeks and test it again. Do plasma amino acids again. Can you do a repeat newborn screen? If your newborn screening lab will do that, you can. They don't have cutoff values in newborn screening labs, and the number may not be as reliable as plasma. So I prefer plasma. But if the only thing you can get is a dried blood spot, that's fine. It'll work. Type 3, extremely rare. So rare we don't really know what the incidence is. It's the 4-hydroxyphenyl pyruvic dioxygenase enzyme. Again, that's the target of nitisinone therapy for type 1. Ocular findings have been reported due to the tyrosinemia. It is responsive to dietary treatment, but we have not seen ocular findings in patients on nitisinone. Now, of course, the reason for that is if you've got somebody writing your prescription for nitisinone, they're probably monitoring your diet pretty carefully, and they're not treating you with nitisinone if you're not using the dietary treatment. Skin findings have not been reported in this disorder, and it's also not clear if there are neurodevelopmental defects here either. And then there is this Hawkinson urea, is this abnormal byproduct that you get when you have a block of that enzyme. Again, intellectual disability, not entirely clear. I think I've never seen a case of type 3 tyrosinemia. My inclination would be to treat them, at least somewhat treat them, to try to keep the tyrosine close to 600 or 700, because there's pretty good evidence that at those levels, you're not going to see neurodevelopmental defects. Seizures have been reported, but there's other complicating factors in those case reports, so it's not clear if the seizures are related to the tyrosinemia. You don't typically see seizures in people with high tyrosine. And there are anecdotal reports of untreated adults with normal development. So is there a role for some of these phenolic metabolites, downstream metabolites? We just don't know. So it's a tough one to know what to tell families. Many people will treat, but I think you could make an argument for being modest with your treatment. Treatment for tyrosinemia, again, restrict dietary tyrosine, try to keep the tyrosine below 600, regular eye and skin exams, and measure development. We already talked about transient tyrosinemia of the newborn. It is common. It's thought to be due to immaturity of the liver enzymes. It's self-limiting in the first couple of months. It appears to be benign. Older literature suggests that giving vitamin C may speed up the correction. There doesn't appear to be any reason to do that, and I don't do it, but some people do. Can't fault them for that. No evidence for or against that. The key is that you should not jump into aggressive dietary therapy, and you shouldn't tell families that the baby has a terrible disease until you've ruled out transient tyrosinemia of the newborn, and you rule that out by time. So I realize I'm going a little bit over time, and I apologize for that. If you need to leave, I understand, but I do want to spend a little bit of time talking about homocystinuria. And homocystinuria is the excess of homocysteine that you see here in cysteine. And again, I'm walking on thin ice here because there are multiple people on this call who know much more about these conditions than I do. But this is the pathway of methionine metabolism, and this is a really, really important metabolic pathway, because this is where you form S-adenosylmethionine, which is one of the most important compounds for single carbon metabolism, DNA synthesis, methylation of DNA. This is an important metabolite right here. Comes from methionine. When you remove the methyl group from S-adenosylmethionine, you make S-adenosylmethionine. homocysteine, and then the adenosine is removed from that, and that leaves homocysteine. Homocysteine is remethylated by this B12 and folate dependent pathway that utilizes 5-methyl tetrahydrofolate as the methyl donor via methylcobalamin to reform methionine. And so there's a lot of different ways to get hyperhomocystinemia. You can have a defect in remethylation, or you can have a defect in this cystathionine degradation pathway. Cystathionine beta synthase is the major defect there. A couple of points to make while we're looking at the pathway. First is that if you have a defect here at cystathionine beta synthase, that's classical homocystinuria. Those kids will have high homocysteine. They will also back up to high methionine. And this is what we screen for in newborn screening. Homocysteine is rarely measured by newborn screening labs. So if you have high methionine, it's most like in a newborn screen, it's most likely CBS deficiency. Not always, there are some other defects that it can be, that those are very, very rare. But if you have a remethylation defect, you are not going to pick that up by screening for methionine unless your lab has a cutoff for low methionine, which very few newborn screening labs do. So lots, complicated pathway, lots going on here, lots of involvement with other metabolic pathways. If you were looking at the Boehringer-Mannheim pathway, you could put this one very close to the middle because it interacts with so many different pathways. So the issue here is that these are sulfur-containing amino acids, and they form disulfide bonds. They form disulfide bonds with other amino acids. They form disulfide bonds with the sulfide-containing amino acids in proteins. And so they can be extremely disruptive in a variety of ways. And these are just a couple of the common disulfide bonds that or compounds that you may see. Homocysteine here, homocysteine, which you see in the urine in people with homocystinuria, is a disulfide. You also see a disulfide of homocysteine, and homocysteine is very common in the urine. Your amino acid lab should be able to pick up that as well. It's pretty easy. A couple things. If you need an accurate measurement of homocysteine, don't rely on anything except a laboratory that does quantitative total homocysteine. Almost every lab does this because high homocysteine is associated with cardiovascular disease. Anything associated with cardiovascular disease gets lots of money thrown at it and lots of attention in the US. And so pretty much any lab can measure an accurate total homocysteine. Also, if you want to be sure you're getting an accurate value, you need to make sure the lab handles the sample properly and quickly, because homocysteine, as said, is this, you have to measure the disulfide, you have to measure, there are various forms that have to be measured. And so you need to handle the sample properly and quickly. Classical homocystinuria due to cystathionine beta synthase deficiency, rarer than, fairly rare, but still often enough that we see it. Many cases or many states do newborn screening for it, but for the classical form by measuring methionine. There is probably incomplete ascertainment though, because methionine is not the primary marker. Homocysteine is the primary marker. And if you're using methionine, which is what most state labs are using, you will miss cases. So we think that we probably miss maybe as many as a third to a half of cases. And that's why the homocysteine community and the HCU society or the HCU advocacy groups are really pushing to get states to start screening for homocysteine and not rely on methionine as the screening marker. It is said that 50% of cystathionine beta synthase mutations are pyridoxine vitamin B6 responsive. Not sure I believe that, but you absolutely have to do a clinical trial with pyridoxine when you diagnose this to find out whether your patient's responsive. And the responsive patients may not completely normalize, but they'll get a lot better. And those patients have much better outcomes and they're much easier to treat. Classical untreated homocystinuria, you get that marfanoid body habitus that you can see here with the long gangly extremities, the arachnodactyly, the sort of slender appearance, scoliosis, osteoporosis. And this is much more common in the non-B12 or B6 responsive. You get a dislocation of the lens in 90% of affected individuals, often bilateral, typically down and toward the nose, as you see in this picture. Anybody who's paying close attention to this will recognize that this picture is actually upside down because it's a picture of a person with Marfan. And if you turn the picture the right way, they would be up and away from the nose. But I flipped it over to show you what the lens looks like in homocystinuria. So I apologize for that. Hopefully you will not feel that I'm as evil as Alex Jones for telling you that little white lie. You also get myopia. The dislocated lens can be an isolated presenting sign, but many individuals will also have developmental disability and neuropsych symptoms. And those are not always completely responsive to treatment. Recurrent thromboembolism is common, especially in untreated disease. We used to think that you had to get the homocysteine really down close to normal to reduce the risk of thromboembolism. I think more recently people are thinking that that's not really necessarily the case, but the goal should be to get homocysteine, blood plasma concentration of homocysteine as low as you can. Sometimes that's 35 micromolar, sometimes it's 80 micromolar, everybody's different. Thromboembolism can be a presenting sign. That can be a pulmonary embolism, phlebitis, a stroke. Environmental factors often are the triggers in people with hyperhomocystinemia, and so smoking, oral contraceptives, anesthesia, all increase the risk of thromboembolism. These are some images of people with atherosclerotic disease related to the disorder. Here you can see a person with homocystinuria that has some narrowing of blood vessels and all these collateral vessels in the lower extremity, as well as a thrombus in the popliteal vein. And unfortunately, in the translation, this arrow got moved because the thrombus is up in here. Thromboembolic strokes, you can see, very unfortunate. So what about other causes of homocystinuria? Here's classical homocystinuria due to cystathionine beta synthase, but also methionine synthase, cobalamin G is a cause. There's other causes, methylene tetrahydrofolate reductase deficiency, not the common variants in MTHFR, but really null alleles in recessive for null or very significant alleles in MTHFR. That's a very bad disease. Being homozygous for the common variants is not a bad disease, probably not a disease. And then others as well. So the remethylation defects are less likely to be thought of. I also want to use this image to talk to you about the treatment for homocysteine, which is that you have an enzyme system in your body called beta-ene homocysteine methyltransferase. Not entirely clear to me what it's doing in our bodies. There's two different BHMT enzymes in the body, and what they do is that this enzyme uses the methyl group from homocysteine and donates it to via this quaternary amine that's originally isolated from beets, from sugar beets, beta vulgaris, and called beta-ene, even though everybody else in the world but me calls it betaine. The actual pronunciation by the people who first synthesized it is beta-ene from beta vulgaris. But beta-ene makes dimethylglycine and accepts the methyl donor, the methyl group from homocysteine, and then passes it on. Well, the dimethylglycine is what's left of beta-ene after you pass the methyl group onto homocysteine to reform methionine. So you can remethylate methionine. And the key here, in case people have to leave, is that part of the deficient in these remethylation defects, part of the pathogenesis is the methionine deficiency. And that can be very severe in the newborn period and can be can cause permanent brain injury and can cause death. So low methionine has to be treated and it has to be diagnosed. And we don't want to miss those cases. Very important. We talked about this already. You measure pyridoxine responsiveness by giving 10 milligrams of pyridoxine per day with a maximum of 500 milligrams. I believe that high dose pyridoxine therapy can cause peripheral neuropathy, so you don't want to overdo it. Usually greater than 900, most people limit their treatment to 500 to 600 to maintain a margin of safety for that therapeutic index for the neuropathy. So don't go over 900. Ideally, don't go over 500. Give 10 milligrams per kilo per day. Test 2 or 3 times before and 2 or 3 times after for homocysteine, looking for a 20% decrease, as long as you're starting above 50 micromolar. Everybody should get folate. Usually the special formulas for treatment, if you're using a formula for homocystinuria, have plenty of both. Diet therapy, I have yet to meet a patient who will stay on diet therapy into adult life, but if you do, it's low protein with a metabolic formula. Betaine or betaine therapy, start at 50 to 100 milligrams per kilo per day. You can actually go up even higher, 200, rarely, some people go up to 300. You rarely go above that, not because it's harmful. We're not aware of any downside of giving betaine, except you can get an odor from the dimethylglycine. But it is, you don't get additional effect. Betaine concentrations in blood when you're giving high doses, it has a fairly long half-life. So if a naive person, when you start treatment, the half-life of betaine might be 14 hours. So that's why we use twice-a-day dosing. But the longer you're on betaine, the longer the half-life becomes. And so there's really doesn't seem to be much evidence for using more than twice-a-day dosing for betaine. And once you are on a dose where you're not getting additional benefit, there's no point in going higher because the enzymes are saturable. So apparently the enzymes are saturable and you won't get additional effect. So other causes of hypermethionine are methionine adenosine transferase 1 and 3, the MAP1 and 3 defect. This is quite rare, and we don't know much about it. We don't really know for sure whether it's a problem or not. And the reality is it's probably like other metabolic diseases, that the most severe forms may well cause problems due to deficiency of forming S-adenosylmethionine, but we don't know that for sure. And we do know that S-adenosylmethionine is an important methyl donor for a variety of pathways, and that in this deficiency, the more severe this deficiency, the less S-adenosylmethionine you will make. People have tried limiting methionine. The problem is that you will reduce the methionine concentration by doing that, but it's not clear that you're not exacerbating the S-adenosylmethionine deficiency, and it could actually make things worse. We just don't know. That said, excessive methionine can cause increased intracranial pressure, and it has been in some iatrogenic cases associated with herniation. So you don't want to let the methionine be too high, but you shouldn't over restrict methionine. And then the question is, should you give S-adenosylmethionine? Well, easier said than done, but it's probably worth a try. I want to amplify something that David Rosenblatt put in the chat, which is that MTHR common polymorphisms do not cause MTHFR deficiency. You should not be testing for those polymorphisms on a clinical basis. You should be sequencing MTHFR if you have a person with a remethylation defect that's not diagnosed, either through a family history or through complementation testing, as David does in his lab, that would put you into the appropriate complementation group, which you could then sequence the specific gene. Thanks for that, David. So that's the end. I went way over. I apologize for that. A few people to thank. I particularly want to point out Johan van Hove, who I think was the person who originally came up with the idea for this group meeting, and for Pete and I, who were part of that conversation. And Pete took it on and ran with it and made it happen, along with Holly Abels, who's no longer here in our group, but was the admin person who made this happen. NAMA, many of you will have gone to NAMA, you know, Jerry and Mark, of course, Jerry Vockley and Mark Corson and Jean-Marie, and we borrowed lots of their slides. And then many of my own mentors and colleagues over the years who've just really been great to me over the years. So I apologize for going over. I'll stop here and be glad to answer any questions.
Thank you, Sean, very much. While we're on, questions for Dr. McCandless. There was some good banter in the chats and good tips in the chats. Thank you to everyone who contributed to those too.
I know there's a lot of people who know more about PKU than I do on here, so this would be a good time to update or correct anything that I didn't get quite right. Hi, Anatolia. Thanks for the comment.
Well, since we are over, I think if there's any other questions that you guys have, Dr. McCandless will be back to talk about newborn screening, which is also germane to PKU and homocystinuria too. So you can always save them for then. And otherwise, everybody have a great weekend. I've got patients to go see. And I'm sure everybody else has things they need to get off to. So have a great weekend, stay safe, and I will see you next week. Thanks.
Pete, can you leave it open for a minute and I'll close it just so people who need to pick up the code for credit can do so.
Yep.
And anybody who has questions, just send me an email or I'll be happy to respond. If I don't respond, send me 2 emails.
I did repost the code, so if you scroll up in the chat, you should be able to see it.
Okay, great. Cool. All right. Well, thanks, everybody. Great to see you all.
Yes, thanks, Sean.
You're welcome.